Definition: therapeutic hypothermia for comatose adults who have had an out-of-hospital cardiac arrest was recommended. In-hospital cardiac arrest in children commonly results in death or in a poor long-term functional outcome in survivors.
Cardiac arrest has a very high mortality rate, and it's due to a variety of reasons. The brain starts to undergo a degeneration, basically a self-destruction, where certain chemical processes start to take place, which accelerates cell death. From the time of arrest to the time you reestablish that circulation is what determines your survivability. By starting hypothermia, by reducing the body's core temperature, you actually stop the internal injury process that takes place on a chemical basis. How you institute hypothermia can vary. Main goal is to try to drop that temperature down to about 32 degrees Celsius within about 3 to 6 hours of the time of the arrest. That's your magic window of achieving that hypothermia. You happen to be picked up by an ambulance who is equipped and educated. A hypothermic cooling blanket could be applied. Ice packs placed into the high circulation areas, the axilla, the underarms, the groins, even around the head. Once you're in the hospital, we have some devices that are more formal or sophisticated in cooling blankets, and then another device that's actually inserted into the main vein of the abdomen that exchanges heat internally very aggressively. So we will also institute other sedative drugs to kind of calm the brain's actions, and also muscle paralytics, paralyzing drugs to prevent shivering, which is a natural response, but that consumes oxygen, so you don't want that taking place. So in addition to the natural coma that the patient's in, the drugs will help, blunt any feeling of discomfort, or, that you're actually cold. Therapeutic hypothermia has not been widely adopted. It's one of these unusual therapies in our world, which we see often with a lot of novel therapies, that's been around and accepted for almost a decade, but has been slow to evolve into common practice. And it's one of the things that we're dealing with from a medical education standpoint, is to get this therapy out to the public and get it instituted in a timely manner.
In medicine, outcomes in the in-hospital setting are significantly better than those in the out-of-hospital setting. Cardiac arrest in children in the hospital is due to pre-existing condition. The initial heart rate in patients, the cause of the cardiac arrest, and the initial resuscitation skills of the responders.
We receive a patient from a different unit in the institution. When the heart decides to not function correctly and we need to do CPR in order to get it back beating normally, we have decreased blood flow to the brain. And that's when people become anoxic. They don't have enough blood flow to the brain, and it can adversely affect their brain function forever. So by using therapeutic hypothermia, we are slowing all that process down, slowing down the metabolism for a full 24 hours, and then rewarming slowly to allow the brain to restart and hopefully come back to its normal functioning state. We try to get them cooled rapidly within 4 to 6 hours after they've had return of spontaneous circulation. That's the first phase, which is the induction, which goes very quickly. And then the maintenance phase is the second phase, and that usually lasts 24 hours. We do keep somebody chilled at 33 degrees Celsius for 24 hours. Following that, we start a 16 to 20-hour rewarming phase. We rewarm slowly because that seems to help the brain slowly recover after it was without oxygen, which all was involved with cardiac arrest. If we receive a patient from a different unit in the institution or from outside the institution, routinely they have already been started with a little bit of cooling down by having ice packs placed under their arms, up around their neck. We also give 2 liters of ice saline over 30-minute time frame, either through a central line or through an IV line. We apply the pads, and there are 4 pads that are placed on every single patient. We have 2 pads that are placed on the upper torso. It goes from the spinal column in the back and wraps around the front. Then we also have 2 pads that are applied on the patient's thighs. If the individual has a rather large abdomen, we want to try to cover as much skin as possible to cool as rapidly as possible. So we do have a universal pad that we can use as well on somebody with a rather large abdomen. Those pads then are connected into the Arctic Sun machine. We do turn the Arctic Sun machine on, and we can set it for hypothermia. And right away, we will start having chilled water moving into the pads. And it's a constant fluctuation and moving. It should be around 33 degrees once the patient reaches its maintenance therapy to maintain them at 33 degrees for 24 hours. Once we have a patient back up to 37 degrees Celsius or 98.6 degrees Fahrenheit, the recovery phase then really starts for the individual. We have seen a variety of success stories through somebody waking up and responding to our request soon after we have them warmed. We have had individuals 2 weeks out. That, not that we were losing hope, but it was really a struggle because we weren't seeing a lot of interaction. And suddenly people will open up their eyes and they do respond to our requests.
Pros and cons. Pros. Patients who were older than 2 days and younger than 18 years of age were randomly assigned to therapeutic hypothermia or therapeutic normothermia. Cons. Among all the patients with data that could be evaluated, the change in the BABS to score from baseline to 12 months was not significantly different.
My favorite save was actually our very first patient.
Yeah, it was quite remarkable, really good save. Just so pleased with that.
My most interesting save that occurred started with a call from the paramedics when the patient had refused to come in and finally convinced them to come into the emergency department.
So one of my most memorable saves was a young man who came to the hospital because he said he'd been feeling a bit nauseated.
My favorite save was actually our very first patient. We got a call.
He was pretty out, comatose. Needless to say, they were frantic, and very luckily for him, he had gotten good CPR.
What's going to happen to the brain?
So what happens with cardiac arrest is the brain is injured by the period of time when the heart has stopped, and then it actually has the capacity to recover when the heart is restarted. However, an injury process is triggered that evolves over hours to days after the resuscitation. And it's during that time that we think there's a therapeutic window where we can intervene with treatments like hypothermia to stop that injury process and prevent the neurons from dying, which will allow people to wake up and return to normal function.
Goyal, Dr. Merchant, what kinds of things in terms of cooling, taking care of other parts of the systems? What do we worry about then after we get their heart restarted?
We have the part we started, and we know that the patient is a candidate for cooling. We start the cooling process right away. We start first with cold saline. We have 2 liters of cold saline kept in the emergency department at all times. We start that actively and then start the surface cooling device. And it's essentially like putting cold saline directly on the patient's body, except it's separated by a thin membrane that keeps the patient from actually getting wet. Much cleaner than just putting the patient in an ice bath, say, or dousing the patient with water and putting a fan over them, which is things that we used to do. So we use the device to wrap both patients' legs and the patient's chest, which still keeps their head, their upper chest, and their pelvis accessible to do other things as necessary as part of their management. So we'll just wrap one of Dr. Abella's legs just to demonstrate. And then pick up your leg, please. We'll generally have this placed prior to the patient's arrival, or we'll roll the patient onto this device. Over. And again, the patient would have no clothes on, so we have a very high surface contact area. See fluid coming, circulating in and out through these pipes. That's taking essentially 4-degree cold saline into the patient and bringing it back to the machine.
Dr. Merchant, they feel this? Is it uncomfortable?
No, so the patients that we typically start in hypothermia are comatose prior to beginning the hypothermia.
Right now in the United States and a little bit around the world, is the average patient learning to cool? What's the deal?
So cooling is sort of in the beginning stages right now, and so not all hospitals have adopted this new therapy. A lot more patients are receiving cooling in Europe and in other countries abroad, and so we're just sort of trying to get physicians more aware of this new technology so they can start cooling their patients so they can have better outcomes and leave the hospital and return to their communities as they were when they came in.
So thanks very much. I'm going to get Mike cooled down. He's looking hemodynamically stable, but he doesn't have any neurologic function by all accounts. At this point, he appears to be brain dead. 5 hours later, I called his ICU nurse. So I talked with her and told her sort of our experience, spent about 45 minutes on the phone. Here's try a little of this, try a little of that, get the temperature down to 34 degrees. She called me back a little bit later. That was very helpful. Thank you very much. Then they slowly warmed him up just the way you should after about 24 hours. And lo and behold, about a day after that, he woke up. I said, how is he doing? And my cousin said, would you like to talk to him? And I said, oh my God, can he talk? Can he talk?
8 hours.
He was out.
He said, actually, doctor, I have to leave the hospital.
She asked me for a Diet Coke.
He said, I will sign your paperwork and
Issue amplified in Ecuador. Trials comparing hypothermia, normothermia, therapeutic show we have no significant difference between the two interventions in outcomes. Possible mechanisms underlying the initial reports of a benefit of hypothermia over treatment conventional is that therapeutic normothermia is also beneficial.
Therapeutic hypothermia is a treatment for a variety of things in that I'm interested in brain injury. And I became interested in therapeutic approximately 2 decades ago when I was working with a fellow named Guy Clifton at Medical College, Virginia. And Guy was demonstrating that in animal models, cooling the animal to about 89 degrees Fahrenheit or 32 degrees centigrade could make a big difference in the outcome of that animal after the animal had an experimental head injury. So that I thought was an important breakthrough because we knew that cooling to lower temperatures could cause some real problems with the heart. In particular, it can cause the heart to stop beating. Uh, Additionally, cooling to low temperatures can cause problems with coagulation of the blood, so that there'll be hemorrhage problems. So I thought that was an important breakthrough and something that could be accomplished in the clinic, in the hospital setting. I began using hypothermia at that point when I returned to the clinical practice, and we did a number of studies. Myself and a number of other investigators did studies with hypothermia primarily for patients with severe traumatic brain injury. And by that, I mean patients who were comatose following the initial impact and were brought to our emergency department unable to follow commands or to interact with their environment. We think that cooling helps to improve outcomes following brain injury from a variety of causes. So you can have brain injury as a result of cardiac arrest, for example, where there's a loss of blood flow to the brain for a period of time. You can have brain injury from a stroke, but more relevant to my clinical interests, you can have brain injury from an impact to the head or trauma or traumatic brain injury. That injury, whether it's from stroke or cardiac arrest or trauma, will cause a period of ischemia or lack of oxygen supply to the brain, followed by inflammation, release of a number of toxic chemicals into the brain, and disruption of the metabolism or the mechanics of the brain.
In comatose children who survive in hospital, cardiac arrest, therapeutic hypothermia. Compared normothermia did not compare with therapeutic significant benefit with respect to survival with a good functional outcome at 1 year.